caused by an external force, caused by a bump, blow, or jolt to the head, or a penetrating head injury that disrupts the normal function of the brain. And if we go to the next slide, there's been recent additions to help with the application of the CDC definition to help us know how to identify alteration and normal function of the brain. So more of the following is required to make this determination, and I have it here in this gray box. Any period of loss of or decreased consciousness, any loss of memory for events immediately before or after the injury, neurologic deficits such as muscle weakness, loss of balance and coordination, disruption of vision, change in speech and language, or sensory loss, and or any alteration in mental state at the time of the injury, such as confusion, disorientation, slowed thinking, or difficulty with concentration. Importantly, as we all know, not all bumps or blows to the head result in a TBI, and not all persons with a TBI will have behavioral effects or a TBI-related disability. But it's the combination of several factors, as well as at least one of these signs or symptoms shortly after the suspected event that is sufficient to classify a person as having sustained a TBI. Next. So we're just going to kind of breeze through some of the figures. These are already quite a bit outdated, just as a note, but these are the most current figures that the CDC is providing. And even in their 2015 report to Congress, they're still relying on these numbers, which is understandable as it took a long time for them to gather this information. But we don't have current information in the same vein as what's presented here up to 2015, 16, or 2017. But I'm sure that that is in progress as we speak. So what follows are some figures from CDC showing rates of TBI over time, and even though they are a bit outdated, I'm sure that the trends are still there and that the data are still applicable to our conversation. In general, total combined rates for TBI-related emergency department visits, hospitalizations, and deaths have increased between 2001 and 2010. They slowly climbed up. There was a peak around 2005, then some things dropped, and then it started to climb again from 2008, 2010. It will be very interesting to see updates to this information now that we're 7 years later. The total combined rates of the hospitalizations, ED visits, and deaths are driven in large part by the increase in the emergency room visits, which are the blue triangles. And in comparison to the emergency department visits, hospitalizations, which are the red, that may look red on your screen, they've remained relatively stable, and the deaths have decreased over time. So there is a difference in which type of visit we're talking about here. And I just wanted to point out for you on this graph, it can be a little confusing, but the green, the deaths, has the scale to the right of the graph. So all other purple, blue, and red goes from the 0 to 900 on the left axis, but the green goes from 16 to 19 on the right axis. So I just want to make sure that I pointed that out for you because it can be a little confusing. Next. I also wanted to point out that these numbers dramatically underestimate the actual occurrence of TBIs, as we all know. It excludes those who do not report and do not receive medical care, those who had outpatient or office-based visits, and also it excludes those who received any sort of care at a federal facility. So this excludes military personnel and those who received care at a VA. And just some numbers for that, from 2000 to 2011, over 235,000 service members, which is about 4.2% of service members overall, were diagnosed with a TBI. Next. So leading causes, and I just had this asterisk here throughout just to remind us that, again, we're talking about numbers that exclude military personnel. But leading causes of TBI for non-military include the following. Falls takes up the biggest portion of the pie. Unknown, just the general category is next. Struck by or against something, and a lot of these happen in sports-related injuries, according to the CDC reporting, motor vehicle accidents, and assaults. Looked at differently, and what's not included on here, but within here, if you're looking at the non-fatal TBIs, the ones that lead the non-fatal TBIs are falls, motor vehicle accidents, and strikes to the head or against the head, as in sports injuries. And the sports activities most associated with this latter type of visit are bicycling, football, playground activities, basketball, and soccer. And it's mostly in our 19 and younger crowd. The leading causes of TBI-related deaths are motor vehicle accidents, suicides, and falls. And for the purposes of this graph that is shown here, suicides are lumped into the unknown or other category because the numbers are so low that they don't really make it into the pie. Next. The injury mechanisms associated with TBI-related deaths vary by age group, and this is always quite a hard graph for a lot of people to stomach, especially when you look at the deaths in children and how they're primarily associated with assault by a very large margin. For older youth, so starting at 5 and above, and also for young adults, 15 to 24, we're looking at traffic and playing in the street and motor vehicle. And then when we're talking about our older population, falls are our biggest contributor to these deaths. Next. I'm not going to go into the details of this too much, but we can come back if we need to. But risk factors for TBI, I'll include, actually, even though it's at the bottom of the list, age and gender. So we know we have these really 3 peaks in our TBI rates, and age is the biggest contributor to that. Also gender, and I'll show you a slide next that's looking at differences in males versus females. Substance use and abuse, school adjustment, and social history can be a predictor of TBI, but also be a result of TBI. SES, personality type, history of TBI, participation in sporting activities, and then I've included at the bottom also, just to remind us, any sort of military deployment. Next. This next slide is just showing that more males than females experience traumatic brain injuries, especially among young adults. I do have a special population note towards the end, which will bring hopefully some awareness that you all may already have, but that I'd like to make sure that we have here together as we're gathered together to highlight domestic violence victims, which are generally more female. Next. This next slide, and I promise there's only 2 more, but it's good to know these basics. 2 more of these graphs anyway. Looking at emergency department visits by age group, and the reason I just point this out is that it's really increased it's increased for all over this time period that the CDC looked at, and increased the most for youth 4 years of age and younger. This could be because we're getting better at not just letting the kids fall off the banister without taking them to the hospital. So it could be that we're just getting better at getting them there, or it could be that the rates are actually going up. But the children 0 to 4 years did have the highest rates of any age group, and that's important. I think a lot of education could go a long way there to continue the good reporting, but also to try to prevent those as well. Next. Just really briefly, this is looking at rate of hospitalizations. So before it was ED visits, this is hospitalizations. And this is just showing that changes in the rate of TBI-related hospitalizations vary depending upon age. Some are decreased, like the tan color, the red color, the green. Those kind of show an overall decline in the time period that we're looking at, and others increase, the pink and the purple, which are the older groups. Next. So just some quick notes about severity of TBI. The severity of TBI is usually classified as mild, moderate, or severe. And we usually use more than one severity indicator, but a lot of people still just use the Glasgow, the GCS, and it is still the most widely used. So the most on here we'll know, just in case, the GCS is a neurologic scale consisting of 3 components: eye-opening, verbal response, and motor response. And you just add the component scores to create an overall score to determine a level of consciousness. So it is very useful for giving us some information about severity, but standing alone as the only thing that's telling you about TBI severity, it can lead to misclassification of TBI. And there's some good studies that have shown that it's not the most reliable indicator of severity. Because of this, and this is from the recent report to Congress, the use of additional criteria is encouraged for use in clinical practice and research. And this chart here, this table here, shows you some of the other information that can be used. So this can include information about duration of altered mental state or loss of consciousness, and duration of post-traumatic amnesia or PTA. Imaging techniques such as CT scans can also be used to identify structural damage that might contribute to the assessment of injury severity. But I think, as we probably all know, the imaging is only going to tell us about our more severe or maybe our moderate to severe populations. Our clinical imaging is not going to pick up on a lot of the more subtle or white matter or just mild things that do actually happen structurally in the brain. They're not going to pick up on it. Even a lot of our research grades don't, unless you do the right type of processing. And so there are some definite issues with using imaging for mild or mild moderate. In research studies, I don't know if anyone on here uses this. I'm interested to know if you do, to see how it's working in your lab. The abbreviated injury scale, or the AIS, has a score for the head and neck region, and it can sometimes, or it has in research studies, sometimes been used to help give information about TBI severity. It ranks injuries on this 6-point scale based on mortality risk, where 1 is a minor injury and 6 is a non-survivable injury. And it can help with the picture of overall severity. Some people not listed here might include information about the modified Rankin or some other kind of diagnostic, really crude diagnostic score to help give us information about severity. But even with all of these, if you feed all of them in perfectly to try to get the right classification, I think, again, we probably all have experience with still not hitting the right note, even with all this information, not quite hitting the mark with figuring out the severity of the TBI. And oftentimes, especially if they're complex cases, it might be best to give a range, mild, moderate, moderate, severe. All right, next. We're just going to briefly go over the different types of TBI. I've divided into penetrating and non-penetrating, or closed head. So the penetrating is PHI, and just we'll quickly give examples of low velocity and high velocity. And then non-penetrating, also known as closed head injury, and dividing that into non-acceleration and acceleration. Next. So for low velocity PHI, the example I have for you here is a blow to the head that might happen during a fight or more of a minor automobile accident, a knife to the head or hitting the head on the corner of the table as you're falling. Low velocity impacts may cause penetrating injuries if the force of the impact is concentrated in a very small area. It may fracture rather than perforate the skull. If severe fracture and bone fragments do occur, of course, things become much more serious. These types of impacts with these fractures are more likely to occur where the bone is thin in the occipital and the temporal lobes. Next, we'll go to high velocity PHI. An example is a bullet or other projectile to the brain. These actually perforate, entry and or exit, or fracture the skull and penetrate the brain substance. And there's a couple of things that happen when you have that penetration. That projectile will lead to a pressure wave that again will have an impact around the point of entry, not only just where the projectile entered the brain. And also, as you know, it's going to carry all kinds of junk in with it. So hair, skin, dirt, bone fragments, all that type of stuff, which can set up sites for potential secondary consequences of the traumatic brain injury, including infection. Next. With penetrating, there's a high mortality rate, and if it is to the brainstem, it's usually fatal. In terms of prognosis, though, if they do survive one day after a penetrating head injury, they have to survive also the many secondary consequences that we're going to talk about in a little bit later. But if they do survive those things, oftentimes their recovery overall is better than someone who has a closed head injury, which we'll talk about shortly, because their damage might be more focal, smaller area that's affected, and not diffuse. So more like smaller focal stroke deficits. Of course, there are exceptions to that. Next is non-acceleration closed head injury. An example is if a restrained head. So if a person is lying on a hard surface or sitting with the head against a surface when the head is struck by a moving object, this is often also referred to as a fixed head injury. I'm going to just quickly show some skull and brain issues on the next two slides, but overall just note as we continue talking that they have less severe deficits than acceleration closed head injury, which we'll talk about after this. So next you'll see on the top part of the figure, primary consequences of an impression trauma. So just look at the top two that are shown on the figure. This, as you know, the skull is rigid, but it is slightly flexible, and any sort of blow in this manner can deform the skull at the point of impact and drive it against the brain surface. And this can cause localized, wherever it happened, it can cause localized damage to the meninges and the brain at the point of impact. And we don't know if it's because of the actual depression of the skull against the brain or because of that negative pressure that develops when the skull kind of snaps back to its original shape that causes the problem. But impression trauma is something that can then cause some secondary consequences and cause some brain damage and primary consequences as well in non-acceleration CHI. If you'll just look at the bottom of that picture, there's also the chance of ellipsoidal deformation. And this is when you have some sort of blunt force that is applied to a large surface area. So we're not talking about a small area anymore. We're talking about, someone hitting you with a 2x4 or something, a large area on the restrained head. The skull is then forced from its usual ellipsoidal shape to a more circular shape. And this creates changes in pressure gradients that can cause an expansion and a moving outward of brain tissue from the center. And by expanding and moving outward from the center, it actually can lead to some tearing and some shearing, especially of those more central structures. And a lot of that includes stuff around the ventricles, which can lead to secondary consequences, the basal nuclei, the white matter, corpus callosum connections. So it can cause some major problems that can lead to some interesting constellation of deficits. Next. Sometimes the non-acceleration CHI can be accompanied by fractures. They may be at the base of the skull where the cranial nerves and the carotid arteries are housed, and you can imagine this causes many more serious complications. And any skull fracture that is going to cause any sort of damage to the meninges is going to need to be monitored very closely, and can have, again, a whole host of secondary consequences because of bleeding, infection. Next. So just lastly, on to acceleration closed head injury. This might be when an understrained head is struck by a moving object, or striking a stationary object, or as in shaken baby syndrome as well. This is a moving head injury, and there are two types that we're going to discuss briefly: linear acceleration and angular acceleration. So if you go to the next one, just very simply for linear acceleration, our skull and our brain are generally in kind of a well, objects at rest. I'll just say this is, the skull is our object at rest. The brain is our object at rest. They tend to stay at rest. The skull, if it's going to be perturbed or moved in any way, it's going to be quicker to respond than the contents that are within it. So it's going to move. It's basically going to smack the back of your brain. And so we had that first injury from this linear acceleration, that coup injury. The brain is going to start moving. The brain is going to kind of catch up with the speed of that skull. The skull is going to stop either by outer force or because it's constrained by some anatomy that's actually tethering it to your body. But objects in motion tend to stay in motion. And so the brain is still accelerating, and it's going to take a few milliseconds for it to respond. And it's going to then smack the skull again. And here we have our contra-coup injuries. Sometimes this is also referred to as cerebral contusions, or cerebral contusions occur because of these types of injuries. And I think another term is translational trauma. Yes, translational trauma. So if you go to next, what we have here are focal damage to the meninges, the brain cortex, and also the subcortical regions where the brain is compressed against the skull. These types of injuries are more likely to happen following blows to the front or the back of the head than the side, just because there's more space for movement. You have more space there, so the potential for movement is greater when the head moves front to the back than side to side. This can happen too, as you know, when the head is moving at a constant rate of speed and is suddenly stopped, like the shaken baby syndrome or shaken impact syndrome, that we don't actually just see in babies. We also do see in domestic violence, and also as in whiplash injuries as well. So just a note on these linear acceleration injuries and how they can actually be manifested in other ways. The next picture is just kind of showing you just kind of a plane of orientation that is showing the linear nature of the movement of the head. And you can imagine then what the brain is doing inside that skull. The next slide is showing you a couple of other scenarios that are related to this type of acceleration injury as well. And then finally, we have next angular acceleration, and this is when a blow to the head is striking it off center at an angle. And so instead of these linear forces, we now have these rotational forces. And this is going to wreak a lot more havoc when this happens. So just quickly, very similarly, the brain is going to not respond as quickly as the skull. It's going to take a few extra milliseconds to respond, but there is twisting and shearing forces, and mostly it's in these midline axial structures, the midbrain, the basal ganglia or basal nuclei, the brainstem, the cerebellum. And when the skull stops at whatever this rotation is, there's going to be more twisting and more shearing. And so the twisting and shearing happens in both directions. For next, on the next slide, I show that the shearing forces are greatest at the boundaries between the gray and the white matter. And this can lead to bleeding and swelling around these major white matter fiber tracts, like your corpus callosum, your internal capsule, which carries a huge amount of sensory and motor fibers, our projection fibers, and the brainstem. In general, angular acceleration injuries are more severe than linear. And the next slide is just kind of showing you how this differs, how the plane and the rotation is now different. It's not this linear rotation that is happening. For the next slide, I would just want to briefly go over what happens as a result of both of these, but more so in the angular, is what we know of as DAI, or diffuse axonal injury. So you have this movement that I'm actually going to talk a little bit more about DAI on the next slide, but just very briefly, not only do we have the DAI, but also the brain can bounce around inside the skull, and you can also get these abrasions and lacerations where the cranial vault is more bony. And so this is going to be more in the frontal, the lower frontal, and the temporal areas, because we have, as I've shown here, there's a lot more of these bony protrusions and places for the brain to get cut, basically, because of this lower part of the cranial vault. Just as a note, it's been hypothesized that it's this relationship of the brain to these bony areas of the cranial vault that it's been hypothesized that this is what makes us susceptible to having our frontotemporal lobes being the basis for cognitive and behavioral symptoms that we commonly see after TBI. And so this is an area of more research. If you go to the next slide, it's just a little more information on DAI. So it's of special interest because this diffuse injury is going to be responsible, again, for the majority of your cognitive deficits. And but it's very hard to capture with imaging. We can't really see it without very special imaging protocols and data analysis. So our clinical imaging is not really going to pick up on this diffuse axonal injury. So I have, they might appear as very small focal hemorrhages, edema, other things that we can't see necessarily, the cytoskeletal damage, you can't see the impaired axonal transport, but these are all things that are happening as a result of this axonal injury. So it's 10:40 now, but I know I didn't start exactly at 10. How much time do we have here?
You have like 6 minutes.
Okay, so I'm just going to basically read the tops of these pages for the secondary consequences, because we know that surviving the initial injury is not even half of the story, I don't think. It's what happens after the TBI, the secondary consequences. And so these next slides are really just kind of pointing out to you the different things that, especially if you're working in this acute unit, that you're going to have to be looking out for as a team, and also know that there's going to be a lot of behavioral consequences because of this. These include traumatic hemorrhage, cerebral edema, traumatic hydrocephalus, increased intracranial pressure, ischemic brain damage, and cerebral vasospasm. And if you can just go, Mark, to the intracranial pressure one, because I think that's the one that will at least take a minute of our time, because this is really the most dramatic and deadly consequence of TBI. This is when you have this pressure generated by the accumulation of fluids within the skull. We know that our volume is fixed, so if something is going up, something else is going to have to go down. So if these fluids are accumulating, then the brain tissue is going to be compressed and displaced. You can tolerate a uniform, slight increase in increased intracranial pressure for a short period of time, but this uniform distribution of the ICP rarely happens. In TBI, usually it's around like a site of injury or inflammation. So one of the main things that happens, if you'll go to actually the 2 slides from now, just to show the herniation. So The most dangerous consequence of increased intracranial pressure is when you have some cerebral structure that's pushed around some barrier, pushed around some rigid partition into another area where it's not supposed to be. This can lead to damage of vessels, to damage of tissue, leakage of fluids that you don't want leaked, a further increase of increased intracranial pressure, and if not treated, it will lead to coma and death. So as you know, a lot of your patients are going to be very closely monitored for any changes in ICP. So if you'll just go on to the systemic complications, I'm not going into this at all. I'm just kind of listing, as you know, that these are things that your TBI patients have going on. They'll have problems with skin, with their eye, with their ear, with their nose, and I'm listing them for you in a little more detail here. The reason things are purple is a lot of people and a lot of speech pathologists even don't know exactly what their roles should be with this population. So the things in purple are actually things that are within your friendly neighborhood speech language pathologist scope of practice. So if they have the proper training in TBI, they should know how to address these things, and they should be a resource for you if you haven't utilized them in this way. That's kind of information for us all as this team approach. On the next page, mouth and throat, larynx, trachea, lungs. On the next page, GI tract, heart, your peripheral system, your genital system, and the female reproductive system. The next page is metabolic, endocrine, blood, musculoskeletal, peripheral nervous system. And then finally, what we all kind of deal most with is the central nervous system. And if you'll go to the next page, that is related directly to these health effects that are associated with TBI, the cognitive, the behavioral, emotional, the motor, the sensory, and also other somatic signs and symptoms that we see associated with TBI. This is not exhaustive, but these are the most common. And also what's not included here really are mood disorders, which we know are a huge issue after TBI and or contributed to it, post-traumatic epilepsy, PTSD, and then of course also the increased risk for dementia. What I'm going to just have for you here on the next slide, I'm really just trying to point out that what we focused on for the most of this talk is really just the body functions and structures and the health condition. We haven't really focused on how this affects activities and participation, how it influences their everyday life, return to work, return to school, return to pre-injury activities, life satisfaction, having some sort of productive role in society, all of those things. And so I think that a brain injury basics should talk about mostly the body structure and the body function part of it, but I wanted to at least have you thinking about how that's only, in terms of their everyday functioning, that's only a very small piece of the story. Skipping over the next slide, maybe we can have a WHO ICF life participation chat added at some point to our curriculum, because our curriculum is so anemic, right? Just kidding. It's very nice. Final comments that I feel like it's really important to mention when we're talking about basics is that as you're seeing patients, as they're on your caseload, as they're coming in and out, there are some things that need to be on your radar for some special populations. So for children 0 to 19 years, we know that it's underreported. We also know that the impact is underestimated, and they're going to live with it for a much longer duration. And so the societal impact, the economic impact, we don't really quite know the burden of that. But what's important with children is that you have the effects of the brain injury that's overlaid on a developmental trajectory. So things that are related to a brain injury that happened at year 2 years of age or 3 years of age, we might not actually see until they're 6 or 8 or 10 or whatever developmental period they're in where it's time to develop this brain function. And so what happens with children, and I know I'm preaching to the choir, but just in case I'm not for someone, this may present as academic failure many years after the brain injury, chronic behavior problems, social isolation, difficulty with employment, difficulty with relationships, difficulty with the law. It can also be misattributed to laziness or lack of motivation or even bad parenting. And so there's something that we need to just be aware of and advocate for in our practice and our research. For older adults, if you'll go, sorry, Mark, I should have told you, sorry. I'm on a couple of slides later. There you go. Older adults are at a higher risk for mortality. They have worse functional outcomes regardless of their initial severity. Their care and recovery is more costly, but what we need to be aware of as practitioners and researchers is that their signs and symptoms are very often misattributed to normal aging. Next. For rural residents, they have higher rates in rural areas. They are underreported, and they also have less access to specialized life-saving care or rehab. And what's important, too, is that they have really, really bad return to work outcomes. So in urban areas, it's about a 24% return to work, and that still includes like return to underemployment, but it's still return to work. Whereas in rural areas, it's about 7%. And so a lot of work to be done there. And that's actually where these teleechos come in quite handy, I think, to get this information out there to the rural areas, if possible. Three more special populations: military service members and veterans. The causes of TBI here are 20% from deployment, mostly blast injury, but 80% from training exercises, from sports injuries, sometimes assaults. It's important to note also, of course, that if during deployment, they're at a huge increased risk for PTSD. Next. Incarcerated populations, there's a high percentage of TBI in prisoners who have been surveyed. A couple of studies have put it at 60.3% or 65% or even 72% in women. So we don't know which came first. Did they have the TBI? Did this lead to a certain lifestyle or certain behaviors that put them in jail? Did they have the TBI while they were in jail? So there's a lot of work that needs to be done. Of course, there are some ethical issues with working with this population, but it's a huge number there. And then finally, victims of domestic violence. They're actually, with all of the focus that's on sports-related injuries and concussion, which is wonderful. What's not talked about are victims of domestic violence, and there are actually way more of TBI that happen as a result of domestic violence, and way more women, especially, living with it than all of these sports injuries. So it's a silent epidemic, really. So just those numbers, and then I'm shutting up, is 90% of domestic violence victims tell ER doctors they suffered head injuries. And they also have hypoxic or anoxic injuries from strangling or choking incidences. And a number on that is 50% of domestic violence victims report being choked or strangled. And so this is something that we need to not let fall through the cracks anymore, if at all possible. So those are basics, according to me. Thanks.
That was an amazing, another tour de force here through all this. So thank you so much for that. I actually learned many things this time around. So I loved your pictures. And I do want to say that two very important things is, one is if I understand it correctly, a lot of women who are victims of domestic violence do not see themselves as having a brain injury. And when you do have a brain injury and you're in a domestic violence relationship, it's even harder to get out of because of the cognitive deficits that are beginning to snowball. And when you're in the shelter here in New Mexico, they really don't appreciate, and they have no way to address people coming into shelters who have brain injuries. So we're working on that slowly here, but it is a huge issue. And this really gets into the bigger issue. Once you've established you have a brain injury, how do you begin to sift through all the ways that it's affecting your life. And that's hopefully we can continue to do that here through this model that we're presenting. With that said, hey, thank you so much for pinch hitting. Oh my goodness, I don't know why we had you pinch hitting. That was really good. Thank you. And then we're going to go on. BJ, are you on video yet? Are you still on? On
video now.
There you are. Sorry, I can't figure out which screen I want to look at anymore. All right, so we're going to go to the case. Let's just run through that real quick. I can do this. Hang on.